Dr. Robert Fox is a neurologist at the Cleveland Clinic's Mellon Center for Multiple Sclerosis Treatment and Research, as well as the Vice Chair of Research at the Cleveland Clinic Neurological Institute. Dr. Fox is also a professor of neurology at the Cleveland Clinic Lerner College of Medicine. He chairs the International Progressive MS Alliance Scientific Steering Committee, and Dr. Fox serves as the managing director of the NARCOM's Patient Registry. Good to see you again.
Good to see you, John. Thanks for having me.
You bet. As I introduced you, our viewers heard just some of the many hats you wear. Those roles provide you with a somewhat unique vantage point over the entire MS research landscape. As you walk these halls and listen to the presentations here at ECTRIMS, what's the dominant theme or biggest buzz you're sensing this year? Is there a particular area, a new drug class, a diagnostic tool, or a basic science concept that has clearly made a significant leap since we last gathered?
Well, what to me strikes me and jumps out is the balance of the risk and benefit of highly effective relapsing MS therapies. And we know that our highly effective therapies are very effective, but we also know that continuing many of them for the long term can have increased risk. I just came from a session where we learned from several different investigators about the longer people are on these drugs, the higher the risks of infections and other complications develop. And so what we're coming to realize is highly effective therapies are effective and are useful in at least some patients, but there is an ongoing risk-benefit trade-off, and it's not static. It is ongoing as patients continue through the disease, as they get older, as they are on these therapies longer, that risk-benefit trade-off may shift and may change.
There's been a major focus on tackling progression independent of relapse activity called PIRA. Last year at ECTRIMS, you presented encouraging results of a phase 3 clinical trial for one of these BTK inhibitors, tolebrutinib, and non-relapsing secondary progressive MS. And we expect to hear whether that medication will receive FDA approval in late December. How might these drugs, which target the innate immune system within the brain and spinal cord, fundamentally change our approach to treating not just relapses, but this underlying chronic progression that's proven so difficult to understand, let alone stop?
Well, we are very effective at treating the relapsing component that comes from the immune system circulating around our body. We know that within the brain, there are processes that are leading and driving the gradual little by little progression in our patients, so-called progressive MS. Now, we don't know exactly what that pathology is, and indeed it may be a mixture of things, and that mixture may be different in different patients. But what we have learned is that the brain-penetrant BTK inhibitor tolebrutinib can slow down that progression of disability. Now, it's 31%, it's not 100%, but that's 31% more than we have already. And again, there's probably a mixture of mechanisms and pathologies that are driving progression, so I doubt we'll find any one therapy that stops progression like we found with relapsing MS. We do find therapies that are very, very effective in stopping all the disease activity. I suspect we won't find that with progressive MS. That said, with tolebrutinib, one of the questions was what sort of patients are more responsive or less responsive? And so presented here was a subgroup analysis looking at the men and the women, older and younger patients, more disabled and less disabled patients, longer disease duration and shorter disease duration. And it turns out that although there was a little bit of variability in the point estimates of the efficacy of tolebrutinib in decreasing the risk of sustained progression of disability, it really didn't change much. There was a little bit of a signal that patients with gadolinium-enhancing lesions may be more responsive, which sounds like what we saw with some of the other therapies, that the more relapsing pathology you have, the more likely you'll respond to a therapy. But the big caveat there is although the GAD-positive patients seemed to be more likely to respond to tolebrutinib, it wasn't patients who had relapses. It wasn't the younger patients. It wasn't the patients with a lower disability. So that tells us that actually GAD is not indicating active inflammation in these patients, although it does indicate that, it's probably a marker for some other pathology that is driving progression. And I'll note that the patients without gadolinium-enhancing lesions still seem to have a benefit. It just wasn't as marked as those with gadolinium-enhancing lesions. So we are learning some how to treat progression, but there's still a lot for us to learn.
For years, clinicians have relied on MRIs and relapses to guide treatment. Now we're seeing an explosion of research into fluid biomarkers like neurofilament light chain and glial fibrillary acidic protein. In your view, how close are we to using these blood tests in routine clinical practice to personalize treatment, monitor disease activity more precisely, and make earlier decisions when it comes to switching therapies?
On the one hand, neurofilament light, or NFL, is a useful tool to identify patients with active inflammation. The big caveat, though, is that I haven't seen any data to show that that's any better than MRI. And indeed, we do know that some patients with MRI activity do not have an elevation in neurofilament. So neurofilament is a not as sensitive test. So it's a little easier because it's just a blood test, it's less expensive, but it's also much less sensitive in picking up disease activity. So I envision neurofilament filling in the gaps between MRIs, but not replacing MRIs and monitoring for the relapsing disease pathology. Now, we've also come to learn that neurofilament does not reflect the progressive component of MS. We had hoped it would, but it turns out it doesn't reflect progressive MS. So neurofilament may be helpful in the filling in the gaps in between brain MRIs. Now, the GFAP that you referred to, that was thought to be a very exciting molecule because elevated levels of GFAP are predictive of future disability. So the hope was that we could also use that as a treatment response biomarker. Unfortunately, what we found is that it doesn't change with treatment. It doesn't change with any of our currently approved MS therapies. And so it's still true that high levels of GFAP predict future disability, but it's not actionable because it doesn't mean, therefore, we should do this therapy versus that therapy, and we can't follow it over time. I mean, we can measure it over time, but it's not useful because it doesn't seem to shift with our therapies.
There's a significant amount of research focused on nervous system repair, remyelination, and neuroprotection. Based on the science being presented here, what do you see as the most viable strategies on the horizon for actually reversing damage and restoring function? And what's the biggest barrier we still need to overcome to make that a reality?
So the two things that I am seeing, and it's old things that we keep relearning, not because we forget, but because they are so impactful and so profound. The one is the impact of physical exercise, of movement, of walking, of whatever the exercise that patients can do. That has a neuroprotective effect. And we're learning some about the mechanisms and how it has a neuroprotective effect, but we know that patients who exercise do better over time. Now, some of our patients say, hey doc, I walk with a walker or a cane, I can't get on a treadmill. Okay, but there are some exercises you can do. There are arm bicycles that patients can do who still have arm function. There are ways patients can be active and we think are helpful. The other facet is learning about the comorbid conditions, the other medical things that are going on with patients and how that impacts the progression of MS. That includes smoking and diabetes and vascular disease like hypertension. And so we are revisiting and relearning the importance of treating these other things, which of course are beneficial not just for MS, but other aspects of health. So it's relearning some of the basic aspects of treat those medical conditions, stop smoking, and encourage patients to exercise. Now, to your question of why has it been hard to do? Well, it's hard to change human behavior. It's hard to get people who haven't exercised to start exercising. Smoking cessation is really hard in people who have a smoking addiction, but it doesn't mean that these are not worthy exercises, worthy efforts for us to attempt.
Finally, looking at the sheer volume and quality of the science presented here at ECTRIMS, what excites you the most? For someone who's listening to our conversation, someone who may have been recently diagnosed with MS, what's the most important message coming out of this conference that you'd like to share with them?
Well, there is a tremendous amount of research being done, and so I think there is great hope in the future. What I'm also encouraged about, and I was reflecting over the last 2 days, is the new faces that I see giving talks that are presenting research. It used to be the same old dogs, and I'm one of them, that would be up there presenting over and over again, but there are a new crop of researchers, new generation of people who are attracted to the field of MS because there is so much we can do, there is so much we can learn, and I would encourage people with MS to look around for ways to get involved in research. Clinical trials, but much beyond clinical trials. There are registries, there are biorepositories where your blood or brain MRIs can be part of longitudinal studies. It's only by studying MS that we can figure out how to treat MS better.
To your point, someone listening to this conversation who wants to take the doctor's advice can visit the NARCOM's website, for instance, where they can register and take part in the surveys you put out, because the information that comes from those surveys, it serves everyone living with MS.
Yes, so NARCOMS is a patient registry. Anyone can go to the website, narcoms.org, and sign up and take a survey twice a year to share with us about their journey with MS and understand their therapies, their different diseases, the symptoms that come up, and they can participate from the comfort of their own home.
Well, wearing all the hats you wear, I want to thank you for doing that, for doing all you do to improve the lives of people living with MS, people affected by MS. Thanks so much for making time to talk with me today.
My pleasure. Thank you for sharing the story of MS with the world. It's good to be with you.
This conversation was made possible through a generous grant from Sanofi.